Hi, Shaf.
Hi, Dirk.
Thank you again for this fascinating lecture and also for taking the time to come to Brussels. You deserve a lot of credit for bringing the field of ex vivo lung perfusion forward. Now, I want to discuss with you this idea of creating hubs to resuscitate organs. Now, let me take you back to the paper you've published with Chris Wickfield, when for the first time a lung from a remote hospital in the United States was shipped to Toronto, then reconditioned in your lab, and then flew back to Chicago for a successful transplant. Was this the moment that you had the idea of creating hubs to resuscitate organs?
Yeah, that was our first idea. I mean, that was a desperate situation, and we did it on a compassionate basis. But it sort of made me realize that this technology is still a bit complex, and that we could look at making it available more widely if we could standardize and centralize the process.
Okay, you said more widely. Is that the reason why you have founded this company, Perfusix, both in Canada and the United States? How do you see this work?
Yeah, well, I think in terms of widespread application, I've seen many people try and learn the technique and have managed to duplicate it, but many more have failed and have troubles with it. I also recognize, as a transplanting surgeon myself, that it takes a lot of time and effort to put a lung on a circuit, evaluate it, and treat it. And most surgeons don't have that kind of time, and it may not even be the best use of a surgeon's time to be doing that. So those two concepts of saying we should do it for the surgeon, and the second thing is making it more widely available to smaller programs that
so
may
you
not have
want
that
to concentrate the expertise and the knowledge into one center.
Right. And the other part is looking beyond the horizon, that if we're going to make gene-modified lungs and use stem cells to repair them, again, how are you going to scale that up?
Exactly.
How are you going to make that widely available?
Exactly. Now, I can imagine that reconditioning comes with a price. So you will invest a lot of time and efforts and new drugs and therapies to recondition this organ. Who is going to pay for the additional value that you've given to that organ?
I think that's going to be the judgment made by society, because we look after patients with end-stage organ failure that are very expensive to look after, and they die anyway with a horrible quality of life. On the other hand, we have organs that we can't use because we can't safely know that their function is going to be suitable to support life. So yes, we'll be spending some money on this side to recondition an organ and make a successful transplant. On the other side, we save in the treatment of end-stage organ failure.
Right.
And finally, I think we'll save in terms of treatment of chronic graft failure. So we really have to look at the whole continuum.
Yeah, okay.
In the short term, yes, the patient, the hospital, will have to pay for the added costs, for sure.
Now, at some moment in time of the whole process, this organ needs to be allocated to a recipient. This is done by a central organization. How do you see this happen with the hub? Will the organ be allocated prior to the reconditioning, or will it be allocated after the reconditioning?
I think, in the adoption phase of ex vivo organ reconditioning, we would have to still stay within the established structures in every country where organs are allocated by organ procurement organizations in a standardized way. So an organ is accepted, and then you treat it differently or transplant it directly, you've accepted it for that patient.
Mm-hmm.
I think looking down the road in the future, that may change. We may say we shouldn't accept it until we know more about it, and then accept it for a more optimal patient, for a more optimal result. Okay. But I think that'll be a later step.
Should you ask informed consent to the patient after the reconditioning, telling him, well, the organ has improved, but it's not optimal yet? And do we ask informed consent?
I don't think so. And if we continue to bring things to the bedside that are actually significant improvements on and proven in clinical trials, then they become standard of care. So as we've expanded how we manage donors, donation after cardiac circulatory death donors, those become standard donors. I think our promise to the patient is to deliver an excellent transplant outcome.
Okay. Now, what is for you the next step to take to make this all become possible in North America? What limitations are there at the moment to bring this to a reality?
Well, I think, we're starting to create the availability. We've got about 10 centers that are enrolled to look at the feasibility of this concept of taking the organ from the donor hospital to a repair center and then to a transplant center. That adds a separate leg that isn't there in standard practice. So people have to get used to that concept, show that it's suitable, show that the different time management is feasible. Thankfully, we've done over 200 of these, and we've worked out a lot of the bugs to show that it is feasible. And if logistics become challenging,
Yeah.
the system is still safe and can accommodate that.
Right. You also mentioned that you need staff to do that, the reconditioning. Will this create a new profession, like an organ perfusionist?
Right. It has actually created a new profession called organ perfusion specialist, and they've been vetted and approved by our medical advisory council at our hospital, and they're trained at Toronto General Hospital and then are being sent out to the organ perfusion centers. So these are remarkable individuals that come from many backgrounds, but we train them so that they can manage the organ in an expert way for us.
Okay. Well, Shaf, this was fantastic to have you here in Brussels, and I would like to thank you again for coming, and it was a real honor to interview a giant in lung transplantation.
Thank you. You're most welcome. It's been an honor to be here, and it's been a fantastic meeting. I learned a lot. Thank you.